بس
Assalamu alaikum, the long clinical consultation day. First scenario, you are the doctor, the emergency department registrar. Joanne, 35 years old lady, present with an episode of slurred speech yesterday. Apart from the mild asthma, she doesn't have any chronic medical problem. She has been referred by the GP to the emergency department. The task is to take history, examine the patient, and address the concerns. Hello.
Hello.
Hi, hello.
Hi, I'm Dr. Ala. I'm the doctor in the emergency department today. Let me confirm you are Mrs. Joanne, 35 years old.
Yeah. Hi, Dr. Ala.
Mrs. Joanne, I'm here today to discuss with you about your health condition and to examine you. Is that okay with you?
Yes, of course.
Okay. It came to my knowledge that you have been troubled with problem in your speaking. Is that right?
Oh, yeah.
Can you tell me more about it?
Yesterday at work, uh, I had like a funny episode of being slurry. I was slurring for almost an hour. I was panicking about it, to be honest.
Yeah, I'm sorry for this. I can understand how much this can be stressful for you. So it lasted only for 1 hour?
Roughly, yeah.
Yeah. And this is the first time to have something like this?
Yes.
Can you tell me what you were doing exactly when this happened?
No, I was sitting, doing my work, and all of a sudden, I found that words are difficult to come out from my mouth. I wasn't able to speak as I'm speaking with you right now.
Mhm.
Um,
Okay. And it's resolved spontaneously from itself.
yeah.
Do you think it's resolved totally, or it's still you have some
No, no,
slurred
no,
speaking?
no. It is completely
Yeah.
resolved.
Okay. Apart from this problem in speaking, did you have any headaches,
No,
any weakness in any part of your body,
no,
any problem in your vision?
no.
Do you have any problem in your vision before?
Um, not at all. No, nothing I can remember of.
Yeah. Did you have any weakness before?
No.
Okay. And during this episode also, did you notice any problem in your balance?
No,
Okay. Any shakiness of your hand or jerky movements?
no.
Okay. Mrs. Joanne, I can see from your note that you have history of asthma. Is that right?
Yeah.
Since when you have been diagnosed with asthma?
Since childhood, but it's never been problematic. I use only inhalers when things is bad, but I stopped using inhaler for quite a while because everything is
Mhm.
okay.
And your asthma is now controlled.
Yeah.
Apart from asthma, do you have no other medical condition I should be aware?
No medical conditions, no.
Okay. Are you taking any medications
Currently, no.
apart from the inhaler before? Are you taking any other medications?
No.
Okay. I'm sorry for this question. Are you taking any illicit drugs or party drugs?
No, not at all. Never ever.
Okay. Did you have any fever?
No.
Did you notice any change in your body weight, like increased weight or loss of weight?
No.
Any lumps or bumps in your body?
No.
Any excess sweat?
No.
Okay. Did you have any history of blood clot?
Um, no.
Any family history of blood clot?
Yeah,
Hmm.
quite extensive actually. My From my mother's side, there is um she had clots, recurrent clots in her lungs and her legs also.
Mhm.
Um uh Cousin also did have stroke.
Mhm.
My father did had stroke. So I was
Yeah.
thinking, to be honest, yesterday, am I having stroke?
Yeah, I'm sorry for this, Mrs. Joanne. It is actually a valid concern. Okay, so and regarding your mother and she had these blood clots. At which age do you think started to have these blood clots?
My mom, she had it when she was young, but
Mm,
I think cousin and father do have it like while they are old.
okay, and did your mother receive any specific diagnosis for her for these blood clots?
No, she barely liked to go to the doctors.
Okay. Uh, do you have any history of mouth sores?
No,
Any source in your private area?
I'm sorry, I didn't catch that.
Any source in your private area?
No, no, no.
Any joint pain?
No,
Any skin rash?
no,
Any rash in sun exposure?
no.
Okay. Did you have any headaches before?
No. I'm not usually getting headaches,
Mm,
like except if I'm having some cold or anything. But no, no, I'm not. I don't regularly have any headaches. No.
okay. Uh, do you have any chest pain?
No,
Any heart racing or awareness of your heart beating?
no,
Any shortness of breath?
no,
Okay. Do you have any tummy pain?
no,
Any change in your bowel motion, like loose motions or hard
no,
motions?
no, no,
Did you not see any change in your water work?
no,
Increase amount, decrease amount. Did you notice change in the color of your water work in the morning?
no.
Okay. Can I ask you about your period? Is it regular?
Period is regular. Yes.
Yeah. When was the last period?
Um, 2 weeks ago.
2 weeks ago. Did you notice any change in the amount, like increase amount or decrease amount?
No, actually, no.
Okay. Are you taking birth control pills?
Uh, no. I'm actually having troubles getting pregnant.
Mhm.
So I'm no.
And since when this problem?
Mm, 3 years ago. For 3 years, I've been trying to start family.
Yeah. And did you seek any medical advice for this problem?
Uh, Not actually. Um, um, so I had two miscarriages
Mm.
in the last 3 years. Yes.
Yeah, I'm sorry for this, Mrs. Joanne. Mrs. Joanne, do you smoke?
No.
Do you drink alcohol?
No.
Okay. Can I ask you, do you drive?
Yes.
But at the time being, I think you need to stop driving, okay, until we assess your condition. Then we will come back to you and give
Yeah.
you the proper advice regarding this.
Yeah.
Is that okay?
No, no problem.
Okay. Can I ask you what do you do for living?
I am an accountant.
Yeah. Any impact of this event on your job or daily activities?
This is the first time I do experience this, but to be honest, Doctor,
Mm,
yesterday I was horrified about what happened, to be honest. I was thinking that I am having stroke because I've seen these kind of symptoms in my father and my mother.
mhm. I
Mhm.
can understand this, and I'm sorry for this, Mrs. Joanne. Sorry, Mrs. Joanne, during that event, did you notice change in the shape of your face, like
No,
it's becoming deviated? Okay, can
no.
I examine you?
Yes, please.
So I'll start my examination by checking the patient observation charts for the vitals.
Vitals are within normal.
Okay, then I need to check her hands for any deformity.
No visible deformity.
Then I will
The
check her.
mhm.
Okay, then I will check her pulse. Okay, for any irregular pulse.
Pulse is regular,
Okay,
good volume,
I
equal
need to check
bilaterally.
radio radial and also radiofemoral delay.
No need to do that.
Then, okay, then, Mrs. Joanna, do you have any history of trauma? to your head or to your
No,
neck?
no, not at all.
Okay, then I need to check. I need to ask her to do pronator drift to elevate both hands up.
Normal.
Okay, to check for any
No
pronator
signs of
drift.
pronator drift.
Then, okay, I need to do finger to nose test. Okay, to check for past pointing or cerebellar manifestation.
Normal.
Okay, then I will do reflexes. I will check reflexes in the upper limb for abnormal reflexes.
Reflexes are intact.
I will check only like superficial sensations for any abnormal sensations.
Normal sensation.
Okay, then I will check her face for any abnormal shape, like any mouse deviation or
facial look appears normal. The patient is
yeah.
well built, not overweight. Yeah.
Okay, then I will ask her to close her eye and to elevate her eyebrow first to check for the wrinkles. Okay.
Yeah,
And then,
facial examination is normal. Facial nerve examination is normal.
okay, and also the hypoglossal to open her mouth. Okay, and check for any tongue deviation.
No tongue deviation.
And okay, then I will ask her also to smile for me. And
smiling is equal, no problem.
I need to check her eye for any pallor, any jaundice.
No apparent pallor or jaundice.
Okay, then I need to go down to her heart. Did you notice any swelling in your leg
No.
recently?
No.
Okay, then I will do examination of her heart. Okay. I will auscultate the apex and aortic and also the pulmonary area for any
S1, S2,
murmur.
no apparent murmur. Yeah.
Then I will also auscultate the carotid, okay, for any bruit.
There is no bruit on the carotid.
Okay, then I will go to the lower limb, okay, to check for firstly the peripheral pulsations, then for any lower limb swelling, edema.
There is no lower limb edema. Yeah.
Then I will ask her to elevate her leg to check for the power.
Power is preserved.
Yeah, then I will check also the reflexes in the lower limb, at least the plantar reflex.
Plantar reflex is downgoing normal. Can you hear me?
Yeah, I hear you. Yes, yeah. Okay. Okay. Do you have any family history? You told me about your father, about the stroke. Any family history of early death?
No, actually no.
Okay. Yes, okay. So can I know what's your concern?
What I'm having, doctor, what do you think?
I appreciate your concern, Mrs. Joanne. From our discussion today and my examination to you, mostly you have a condition which is called mini stroke. Regarding your concern before about that can be a stroke, it is not actually a total stroke. It's what we are calling mini stroke, which is blockage of one of the blood channels, which is supplying your brain with a blood clot, and which is totally resolved now. Are you following me?
Yeah. 2 minutes left.
Do you have any questions or concerns?
Am I too young to be having this kind of thing?
Yeah, I can understand this. Yes, it's a valid concern. Actually, there are, from our discussion today, there are multiple explanations of this condition. One of this that it can be a problem in the defense system, which mistakenly attacking blood channels in your body, okay, and increasing the probability of forming blood clots in the blood channel. And this condition may be related also to the pregnancy loss and the miscarriages that you have that you have faced before. Okay, so to confirm this, we need to run some blood tests and to run some blood tests, and maybe also we will do imaging for your brain to confirm our diagnosis.
Am I need to be admitted, doctor, or you don't think so?
Actually, Mrs. Joanne, it's a valid concern, as this is the first time to have something like this, and it's totally now resolved. I think no need for admission, but we will arrange for you at the same day to be seen by the brain or the brain specialist to assess you, and then he will give you the proper advice also later. Is that okay with you?
Yeah.
Okay. There is another explanation also. It can be some sort also of problem in defense system that can attack the brain. It can cause also symptoms like this. We will confirm this also with the imaging that we are going to do for you. Is that okay?
Okay. Time's up.
Okay.
Yes, time is up. Examiner questions.
Thank you, Dr. Ala. Can you please present your findings?
So this lady, she's 35 years old. She has a history of bronchial asthma, which is controlled, presented with sudden onset of slurred speech, which is lasted only for 1 hour. And from the history, she has only history of recurrent miscarriage, which happened twice. And also she has family history with repeated blood clots. Okay, on examination, I couldn't appreciate any positive finding. So my first differential for this lady is transient ischemic attack, which can be due to thrombophilia, maybe due to antiphospholipid and syndrome.
Good. Thank you, Dr. Ala. Any other possible differentials for this lady's transient ischemic attack?
The other differential can be multiple sclerosis. Okay, although there is no other previous attack, but this can be the first attack. The other differential can be also inherited thrombophilia, as she has a family history also with positive thrombophilia.
Okay. Considering if you found, or before this question, how you would like to manage this patient?
So I'd like to do for her basic blood test. I will do a full blood count. I need to do for her urea and electrolyte, and also creatinine and liver function test. I need to do for her ECG, and also I need to do for her echo, and I need to do for her carotid Doppler, and I need to do for her thrombophilia screen. I need to do for the antiphospholipid syndrome, I will do lupus anticoagulant, anticoagulant antibody, and I think anti-gliadin, lupus anticoagulant, got the
Yeah.
other one. Okay, and also other autoimmune profile like anti-nuclear antibody, anti-double-stranded DNA. And also I need to do for her MRI brain.
Any specific model for that MRI?
Especially diffusion
Weighted, yeah.
diffusion weighted to check for any stroke.
Yeah. Yes, this is the investigation. And would you like to involve any other medical teams in her management?
This patient, will involve the multidisciplinary team, including the neurology and also the hematology, and maybe the rheumatology also, and also specialized nurse. We need firstly education and counseling about her condition. And if we confirmed the diagnosis and it is antiphospholipid syndrome, she may need to take therapeutic anticoagulation.
Okay. Is there any specific duration for that anticoagulation?
I think with antiphospholipid syndrome and this event of stroke, she need to take it for life.
Thank you. One more question. With regard to establish a diagnosis of antiphospholipid, what results that you are suspecting from her bloods you just ordered that might support your suspicion of antiphospholipid?
We can also check inflammatory markers, the ESR.
Okay.
Uh,
Have you checked for the coagulation screen?
I think the coagulation,
Yeah.
to check for
What you are expecting in that?
the BTT.
Okay.
Yeah.
Mhm.
BTT will be elevated, I think.
Yes, it will be raised, yes.
Mm.
And one more question. If you noted that this lady did have systolic mama, what other investigation you would like to do?
I will do for her echo. Okay.
Any specific model of that echo?
Yeah, we can do for her if we are suspecting that she has paradoxical imply. We can do bubble echo
Yes.
to check if she has right to left shunt.
Yes. Thank you. Thank you, Dr. Ala.
Thank you.
Perfect. Really amazing. Full mark from me. If Dr.
Yeah, full mark. Yeah.
Yes, really, no comment from
Yeah.
any point.
Yeah.
Yes. Yeah, you can comment also if he missed anything to correct something.
I think the only thing that I will comment on is which is not to is from a criticizing point of view. No, it's just a reminder. So the question was, what's the differential for this lady transient ischemic attack? So I don't think that multiple sclerosis would explain the transient ischemic attack. So this is the only thing that where you said MS, but the rest of the performance would cover for this, to be honest.
Yeah, I
Even
agree,
though if
but
it's slipped.
yeah, it will
Even
not minus him, but it's risky to say multiple sclerosis. However, it can happen, but you have to have other signs of multiple sclerosis.
yeah, other way it should be proposed the idea of multiple sclerosis, which is a good way that Dr. Ala thought of it, that could explain her symptom, the transient that it was for short time, but it is less likely, or
Yeah,
if it came like this. But بسم الله ما شاء الله يعني great job, Dr. Ala.
yeah, I agree also.
Thank
I
you,
cannot,
Dr.
even the differential, I cannot minus him for this differential. But take care, Dr. Ala. Don't give other differential to the patient. Don't be volunteer to tell her I have other possible, because you mentioned already that the one on the top of your differential, which is TIA. It's correct, 100% correct. No need to mention I have other possibility unless she asks you, doctor, it could be something else. Okay? But don't be volunteer to tell about other
Yeah.
differential. The patient doesn't want to hear one and two and three. Okay? Even
One
if
more.
your diagnosis is not correct, you give one explanation. That's it. The workup, the differential, this is for the examiner, not for the patient, unless he asked or she asked you about. Okay. Yeah, one more comment. Sorry, I
One more,
remember,
no,
Doctor.
no, one more question. Dr. Bassem, you have comment. No, no, please proceed.
Okay. Yeah, the last comment. It's the only comment also. Whenever you have abortion, you have to know at which trimester.
Yeah, that's what I I remember at the end.
Yes.
Yes.
Why?
Yes.
Give me the explanation. What could be the explanation? And what the significance of this point?
Yeah, I think for the unphospholipid syndrome, it should be after the first trimester.
During, not
The,
after, during the first trimester.
During the first 6 weeks.
Yes. So it
during the
happened
first trimester.
earlier. Yeah. So you have to specify and show the examiner. It's a matter of showing I'm expert enough to confirm my diagnosis even with the history from the history taking. Okay, this is the most important point in the. It's not only in this scenario. Any scenario you have something positive as a finding in the history, analyze it, please. You and Dr. Musa and Dr. Omar, everyone. I have miscarriage. I have to analyze it more. What the problem if I ask when exactly happened? Which trimester, which part of your pregnancy? Is it at the first part, earlier on the month, or later? You have to analyze, like you are showing the examiner that you are taking care. There is something I picked up. I'm showing you that I'm taking detailed history about this positive finding. Not only overlook it and skip to the next question. Okay, try to do this whenever you have positive finding. Otherwise, really, it was amazing performance from the start till the end.
Yeah. One more question that I wanted to ask in the questions. Uh, from now till you confirm the suspicion of antiphospholipid, what medication you would like to start the patient on?
I think therapeutic anticoagulation will start.
Usually, if you have a transient ischemic attack, yes, you have suspicion for a reason, but you still didn't confirm. I'm asking this question not to test, but this is
Yeah.
question to agree on. At this position, I felt that I would start the patient on aspirin upon the review. After she had the review of the neurologist, I would start her on. He will switch her to clopidogrel, and then till she have the diagnosis, they can stop both and start warfarin. I feel it should be phrased this way. I don't know if Dr. Basim and you agree with that or not, because I don't have the exact answer for this, but this was the question wasn't asked in this scenario, but it can be asked.
Yes, you're right. But for the antiphospholipid, particularly, there is another management if you already diagnosed.
No,
Okay,
no, you are in this scenario still.
anticoagulant.
You are suspecting.
Okay, for the suspicion, you start with dual antiplatelet for 21 days, then you will switch to single antiplatelet if you don't
Okay.
have other pathology. So it's
Okay.
that 21 days until confirm the diagnosis. If it is AF, is it thrombolic or embolic? You have to know what's the type, or the patient will be anticoagulated lifelong, like in our scenario today. The question will be added here if you want to add what are and how much the target INR in this patient.
Two to three. If it's recurrent, if it does have the second one, 3 to 4. And then I think this is arterial event, not venous. So if I'm not mistaken, it should be 2 to 3 for the first attack.
Yeah, and for the recurrence, you will add or you will increase the target to 3 to 4, as you said. Okay, and lifelong again. It's
Mhm.
not as provoked DVT. It's lifelong one.
One more thing, Dr. Ala, you didn't mention is the medical management in your management plan. What medication you should. I think this is the case with the flavor, with the acute flavor. They will usually bring one case of acute flavor, one case with more
Yeah,
chronic symptoms.
chronic.
So I felt, but your overall performance, mashallah, was covering these bits. But if someone is really,
Because
difficult.
I was searching for something to manage, the patients with risk factors, like to manage the hyperlipidemia, to manage diabetes, hypertension. This patient, only the risk factor for her is the thrombophilia.
Uh,
So, and also her slurred speech resolved, so she doesn't need any support like physiotherapy or. So
no, no, no,
what
no.
medical?
It's the medical. No, the medication management. You didn't
Yeah,
state the medication in your chain of thoughts when you are phrasing the management. When you verbalize the management plan, you didn't mention anything. What medication you should start this patient on? She's seen by you. You are now
yeah.
taking care of her
I
care as a
You mean
medic from the
to
medical
the
team.
patient or to the
No, 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 no. To the examiner.
to
When
the?
the examiner
I
asked about the
I
management.
told the therapeutic
Yeah.
anticoagulation.
Oh, okay. Maybe no, I'm sorry. Maybe I missed the
And you asked me for
exactly.
how long?
Oh, yeah, yeah, yeah. But like as from the start, whenever we are suspecting or discussing, they might expect you to state the management of transient ischemic attack. But this is not to criticize anything. Did you get
Yeah.
my point?
Yes. Yeah.
Yeah.
Okay, to emphasize the point of referral or admission, TIA patient should be referred as urgent to the neuro,
Same day, yeah.
yeah, or
Within
TIA
24.
clinic within 24 hours. Exactly. What test and scans you have to do within 24 hours, started by MRI, DWI, diffusion weight imaging, then a carotid Doppler, echo, Holter, thyroid function, which I also prefer to ask about any weather preferences. So, but you ask other question to rule out any thyroid disease like constipation or diarrhea, the amenorrhagia, but better to ask it specifically for the thyroid itself, any weather preference. Just to rule out AF, okay? AF associated with the thyroid or hyperthyroid state or thyrotoxicosis, whatever, okay? Again, it's really good approach, good performance, systematic, organized, driving, everything you didn't miss. Even if you miss small thing, the examiner will leave it and he can give you good mark for your approach. This is the optimum approach you can do. And again, if you didn't say of or you missed something which is maybe can be forgiven by examiner or forgiven by examiner, they will give you even the full mark without mentioning this thing. As I said in our scenario today, the target INR or those things which can be again overlooked by examiner and he will give you the full mark. Okay. Thank you, Dr. Ala. Really, it was a good discussion, good scenario, good approach.
Thank you, Dr. Bassem.
Yeah, the differential. Yeah, what I wanted to say, the differential of multiple sclerosis, you did also as not or it's not the first, but you put it as second. It's okay. The pronator drift, even the examination was perfect to the point. The pulse, the pronator drift, the cerebellar. I think you did the finger and
Yes.
finger nose tests. The eye, you can offer also the eye, or you can ask about if you want to say it could be as multiple sclerosis. You can ask about ophtho phenomena, but it's okay not to mention it because it was something comes and go, or comes and goes, or it's already resolved. However, multiple sclerosis also can appear in relapse, but this is the first time you can suspect it, but it's third maybe or third differential, not as second one. Here it's a direct and straightforward case as TIA. Okay.
So in the exam, when this case came, um, the simulator or the actor didn't volunteered herself to go through the pregnancy history.
You mean as a question?
Yeah. She was answering um, um, uh, the pills, the partner, and then the pregnancy. She didn't volunteer
Mm-hmm.
to say it. So he was asking, "Have you been pregnant?" She said, "No, but I'm trying." So he picked up and started to ask.
Yes. Take care. You have to raise it by yourself. Sometimes yes, she might hide it. No, doctor, I am not pregnant. And she will not answer more. Maybe instructed by the examiner that don't say anything unless the candidate ask you any previous miscarriage. Maybe this is the time to open up and to tell you, yes, I had before. So three P's in female history are very important. Three P's: the pregnancy, the pills, the period. Here, the pills itself can make sense,
Yes.
yeah, as a cause of thrombophilia or as a history of clots.
Yeah.
Yeah, so it's good to ask and also to ask about the miscarriage. Again, if you have miscarriage, you have to know at what trimester or at what time of or at what part of the pregnancy. The family history, perfect question again. The blood in urine or urine dark early morning, which is also good question for hemoglobinuria, mouth sores, and private area ulcer for Behçet, and also the illicit drug. Really, it was again amazing one. You try to rule out all the clotting history or clotting factors that can be affected. I don't have really comment, but I'm trying to summarize and to to recall the points that can be missed, and you should do it. Okay.
So the differential diagnosis for transient ischemic attack start from the neck, from the carotids. This is the source of potentially source of emboli. This is as an embolic, not a vasculitic or inflammatory. Then valvular atrial myxoma, or infective endocarditis, rheumatic heart disease, and congenital heart disease that might cause paradoxical emboli. And then the vasculitic and the last one would be um, the thrombophilia. The thrombophilia and sickle cell anemia as a part of the sequestration crisis.
Perfect. Yes, it can be also one of the differential. However, you cannot cover all of them. But if you couldn't reach to a diagnosis, you have to analyze all these or to research about it. Uh, I want to add also the last, hopefully the last comment. Whenever you want to screen Dr. Ala, try to make it as organized way. General, specific, bedside, and imaging invasive tests. And the examiner, he will ask you about what do you know about the specific? What do you know about the general? What do you know about the bedside? You can mention all what you mentioned, but you can do it as a separate and organized one, rather than saying it one by one. I will do CBC, coagulation, vasculitis, echo, ECG. You did everything, but not in organized way. This is an advice. If you can do it in this way, you will not forget anything. But if you do in
Yeah,
this
that's
way,
true.
you might forget some of the investigation which is important, like Holter. You mentioned also the Doppler, carotid Doppler for the carotid stenosis is also perfect in this scenario. You have to consider it whenever you have the TIA. So it's one of the mandatory scans to do the carotid Doppler for stenosis.
Yeah, the ABTT is expected to be increased,
Yeah.
and potentially could be thrombocytopenia. And one more tip, if the regarding one of the antiphospholipid and one of the antibodies, exactly hematology. It's associated with more risk if it's positive APL.
You mean
The
micro
lupus
glycoprotein
anticoagulant. No, no, the lupus
beta 2?
anticoagulant. No,
Yeah.
no, the lupus anticoagulant, if positive, 5 to 15 times increased risk of recurrent attacks. The other two is not associated with increased risk. This is the to adding up spices since we've opened the antiphospholipid topic. Um, uh, what else? Um, if it's a case of antiphospholipid without any sequelae like any stroke, mini stroke, any venous or thromboembolic picture, the primary prevention would be low dose aspirin. But if there is transient ischemic attack, stroke, or heart attack, or any thromboembolic DVT, PE, then you start anticoagulating. I think we've covered all of the bits and parts in this. Expected rash in this case can be lividoreticularis skin rash.
Yeah, I'm reminding Dr. Ala about the last and the third antibodies to be screened. Beta 2 glycoprotein, not beta 2 microglobulin.
Yeah. I remember
Yeah.
that.
Okay.
Yes.
Yeah, glycoprotein. Dr. Awad, I think. Remember L for L, glyco for AL, APLA, glyco for L, APLA.
Mhm.
So the micro, yeah, the one you mentioned, it's for multiple myeloma, microglobulin for multiple myeloma. Okay, it's not for the antiphospholipid. Antiphospholipid, as I said, beta 2 glycoprotein. The second, the cardiolipin, and antiphospholipid antibody. Okay.
Mhm.
Any other question for first scenario before moving forward?
Yes, Dr. Basim, need for full neurological examination, like reflexes, power, everything, or no need in this case?
Yes, you have to know because he's presenting with neurological manifestation.
Okay. Need full tone, power, reflex, everything.
Tone, power, reflex, coordination,
For upper and
and
lower limb.
superficial. No. You cannot do all of them.
Mm.
Okay. Try to choose the side or both side, of course, but you start with the affected one. If he had right weakness, you have to start with the right upper limb, for example. And you are doing them together, by the way. You're not doing one by one. Okay.
Yes, okay.
Sensation, don't do all the deep sensation. You can do one for the superficial and one for the deep. Okay, Dr. Ala, you can send your scenario.
I think
Yes,
it's
you sent
been
already. You
sent.
are the doctor in the
I
medical
put
technician.
already.
Yeah. Miss Kay,
Mr. Keith, yeah?
Miss
Miss
Kate.
Kiss.
Yeah,
Miss Keith.
35 years old, present with palpitation. 2 minutes, then we'll start, Dr. Omar, okay?
Okay.
Nick, Dr. Ahmed Mansour, neck pain for dissection in history. Okay, it came before, but it's very rare case, but it came before in cases. As you mean a vigorous movement of the neck, so you have a dissection of the carotid, right? Whenever you're ready, Dr. Omar, let's start.
Yes, shall we begin?
Okay.
Yes, here you go.
Hi, hello, my name is Omar. I'm one of the doctors here today in the AMU. Are you Miss Keith?
Yes, doctor, I am.
Okay, Miss Keith, it's been brought to my attention that you are here today because of awareness of your heartbeat, you're feeling palpitation. Is that right?
Yes, doctor, it's right.
How can I help you today?
Actually, doctor, I have this heart racing. It's increasing all over the last 2 months. I tried many things like to be calmed down. I was drinking excess coffee and tea. I tried to decrease the amount, but also it's not effective. So I came for you today.
Okay, I'll try my best to resolve this. I'm sorry that you are experiencing this at the moment. Do you feel any palpitation right now?
No, doctor.
No. Okay. So this problem has been happening for the last 2 months, although that you've tried to cut down alcohol and coffee. Is that right?
Yeah, the coffee. I
The
was
coffee.
drinking too much coffee and
Too
tea,
much
but
coffee.
now I am decreasing. But still, also I have these attacks.
Okay. And it's there all the time? Have you noticed anything that will bring it up?
No, doctor.
No. And have you noticed any pattern for this palpitation? Does it come the beginning of the day or with changing position?
Yeah, sometimes when I'm changing my position, yeah, I feel it. Yeah.
Okay, so when you stand up or stand up from sitting position or stand up quickly, this happens.
Yes, sometimes. Yeah.
Okay. Have you noted any shortness of breath?
No, doctor.
When you lie down flat, is it difficult? Are you able to lie flat usually?
Yes, it's okay.
Any episodes during nights when you are waking up, gasping, like wanted to open the window and breathe some fresh air?
No, no,
No. Any chest pains?
no.
Um, during those 2 months where you experienced the symptoms, this palpitation, have you ever had any loss of consciousness?
No,
Any falls,
no.
dizziness, fatigue?
Yeah, so yeah, I feel dizzy. Yeah,
All the time or when you change position?
yeah. When I change position, yes.
So when you change position, you feel this palpitation. Did it stop at resolve on its own or it
Yeah,
continues?
no, it stops its in its own. Yeah,
Um, after how long it lasts, if you don't mind?
I think it's not long time. We can talk about seconds up to few minutes maximum.
Hmm.
Less than few minutes.
Okay. And it comes only when you change position. So if you are,
Yeah, but sometimes it comes from its own. Sometimes I feel my heart beating fast also.
is it like in form of attacks without anything provoking these attacks?
Yeah, sometimes. Yeah,
Okay. Have you noted anything that would provoke it?
no,
No. Okay. Do you have any weather preference recently?
no,
Swelling in front of your neck,
no, doctor.
eye changes?
No,
Um, with regards to your body systems, have you noted any change of your bowel habits,
no.
any changes within your urine,
Like what?
becoming more burning, any burning sensation or any bubbling,
No, no,
any change of the color?
no, doctor.
Okay, any change of the amount?
No,
Okay. And with your motions, have you noted any changes of your um stool characters like smell, odor,
no,
um,
doctor.
color? No.
No,
Any tingling, numbness,
no,
weakness,
no,
any joint pains,
no, doctor.
back pain,
No,
pain in the back of the neck, pain in front of the neck?
no, doctor.
No. Okay. Any change to your weight recently?
No,
Fevers, night sweats?
no. It was before, but now no.
You mean night sweats and
No,
fevers?
the fevers,
The
fevers.
fevers.
Yeah,
Mm-hmm.
because I had COVID 2 months back, and but
Okay.
yeah, but it resolved now.
Okay, and the problem started after that?
I think it's more after this. Yes.
But it was before this, before you catch the flu or the COVID.
Yeah, before I think it was happening, but not that much.
Mm-hmm. Mm-hmm. Do you have any chronic medical problem for which you are seeing doctors or nurses regularly for that?
No, doctor.
Are you taking any regular medication?
No.
Have you been hospitalized for any medical reason?
No.
Allergies
No.
to food or medication?
No, doctor.
Do you have any family history of any medical problems, any problems in the glands?
No.
Do you mind to tell me what you do for a living
I'm a secretary, doctor.
and how's this symptom affected your job?
Yes, it's affecting me a lot, doctor. Sometimes I'm not able to go to the work, and also my mood is not good also.
So you,
I feel anxious. I cannot deal with my colleagues also in the right way.
oh, you mean that your mood is low, but is there any agitation, loss of temper, if I allowed to say that?
No, only my mood is low, and also
Mm.
I feel like anxious only,
All the time?
especially most of the time, yes.
And it's not related to the episodes, you think, or it's there on the background and the palpitation
Uh,
happens every now
I
and
think
then?
it's aggravating my problem, yeah. I'm
Hmm.
feeling also this heart racing is aggravating also my problem, yeah.
Do you drive?
Yes,
Okay. And do you drink alcohol?
yes,
Do you smoke?
no,
Ever smoked?
no.
How many units of alcohol you drink?
Occasionally, doctor, not
Occasionally.
regular. Yeah.
Okay. And um, you've have you experienced any dizzy spells or symptoms when you are sitting in a sitting position?
Yes, sometimes I told you when like I'm changing position, I feel dizzy.
No,
I
whilst
feel
behind the wheel when you are driving.
actually I didn't notice, doctor.
Uh, as a precaution, I would advise you to stop driving for now
Okay.
till we have a 360 look around what's going on with your heart. Is that okay with you?
Yes, doctor, it's okay.
And do you still drink any caffeinated drink, fizzy drinks?
Actually, I decreased the amount that I was taking before. I was taking like 5, 6 cups per day. Now I'm
Oh,
taking 4 cups per day coffee.
okay. I guess it's still a high amount, even though the four
Hmm.
cups, if you don't, I'm not judging, but I would
Hmm.
advise that this should be go less than that. Um,
Okay.
do you have any particular question or concern today?
Yes, doctor, I'm concerned about this heart racing. What's the problem of it?
Hmm.
There is a problem in my heart?
Well, I would like to examine you in order to complete the picture, and then we will discuss this after the examination. Is that all right?
Mm. Yeah, okay, doctor.
So I'll start um, doing general examination, asking for chart for vital chart if it's available.
Yeah,
Um,
it's normal.
Normal.
Blood
Okay.
pressure 120 over 80, heart rate 80,
Mm-hmm.
temperature normal.
Mm-hmm. I would like to check for the pulse, equality on both sides, and the pulse character,
Yeah, no special character, pulse equal
and
bilateral.
I check for the hand. Is there any tremor? Any changes in the nail? Any
No, mm,
no
got no
changes?
tremors, no changes.
Okay. And lying and standing blood pressure, is it applicable to obtain or if available?
No need.
Okay. And then I'll check for the jugular venous pressure. Um, and is it raised normal?
Normal.
Normal. Okay. And the
Mm.
gland and I will check for the inspect the neck for any thyroid uh gland, any goiter if it's there, and then I'll check the eye for
How
anemia.
how you will check the thyroid?
the inspection from the side,
Mm.
and then ask the patient to swallow, to offer her a cup of water if available
Okay.
on the
Yeah.
bedside.
Yeah. No swelling, no goiter.
No swelling, no goiter. And is there any visible anemia in the
Okay.
palm or within the eyelid?
No pallor.
No pallor. Okay, I will uh, auscultate the heart, do a full cardiac examination, auscultating the heart for any noticeable murmur in the mitral, and then ask the patient to sit to examine the tricuspid and the pulmonary and the aortic, and check
Mm.
the neck for the Berry.
Okay. Normal S1, S2. Uh, no, no murmur.
I'll check the lymph nodes in the neck under her arms also. And then I'll auscultate the back of the lung, check for any sacral edema.
Okay. No edema.
I'll palpate the abdomen, superficial and deep, and then check for organomegaly and renal ballottement.
Mhm. Nothing.
Lower limb um, inspection for any scars, any skin rashes, any lower limb edema.
Nothing.
Okay. Uh, I think um, the examination is completed.
Mhm.
Um, is there any obvious changes in the eye?
No.
No changes in the eye that would require ophthalmoscopic examination.
2 minutes left.
No problem. Miss Keith, um, well, I guess everything from your examination is normal to me. Um,
So
but
do you think I don't have heart problem, doctor?
well, at this time from the examination, I don't think so. But I still would like to look for potential causes for this palpitation,
Mm.
which can explain. We call this disturbance of the rhythm of the heart, which is arrhythmia.
Mm.
Therefore, we need to send some blood tests, and we need to send you with a device to monitor, to record
Mm.
the heart rate during the day and whilst you are asleep. We will do an ECG right now to
Mm.
for the sake of the completion of everything, and we will send some blood tests to check for some of your gland performance to make
Yeah.
sure that we are not missing anything.
And what do you think, doctor? What do you think? What's the cause of this heart racing that I have?
Since it's becoming as an episodes, I think from what you've told me, would be starting from some stress, going to some raised um, adrenaline that's been pushed from the glands. We need to test for that. It would require some arrangement. We need to rule this out. Um, it could be also related to the coffee, which
Mm.
I advise you to cut it down. Would you be
Okay.
able to do that?
Yes, doctor, I'll try it.
Time
Yeah.
is up. Examiner questions.
Okay, can you present your finding and the possible differential diagnosis?
Well, today I've examined Miss Keith, who has presented with 2 months history of episodic palpitation, although she hasn't had any palpitation at the time of assessment. She described that she does have these palpitations um, um, on random episodes, but she also mentioned that there is a changing of position would aggravate it.
Mhm.
Um, she doesn't have any relevant past medical history. She's not taking any medication, but
Mhm.
she drinks a lot of coffee, although she tried to cut it down, but it's still 4 cups a day is quite
Mm.
high number for that.
Yeah.
I didn't notice any positive finding on my examination from the general physical examination or the body system examining her heart or her abdomen. Um, um, so I think my differential could be we need, after ruling out the organic causes for that, which can be pheochromocytoma, or we can, it could be arrhythmia. So we need to
From
arrange
from the from the point of view that she told you that she had a palpitation with changing position, what comes
postural,
in your mind when
um, for postural hypotension
yes?
can be one of the can be one of the causes,
Okay,
but it also can be part of the stigmata of pheochromocytoma sometimes. Um, she didn't have any signs of dehydration, to my point of view, to be honest.
okay. Any other differential comes to your mind?
No, at this time, no.
Okay, you told about postural hypertension, and you told about pheochromocytoma, about the coffee.
Yes,
Any other?
it could be psychological, stress related,
Mm.
but
She
we
told
need
you,
to,
yeah.
in order to say that, we need to rule out the organic causes beforehand.
Mm. Mm. So what you will do as a workup for this lady?
So starting investigating from bedside, I would like to have the lying and standing blood pressure, capillary blood glucose, urinary depth, and then simple ECG, chest X-ray, routine bloods, including um, thyroid function, as well
Mm.
as infection markers, moving to specific investigations, which would be morning cortisol level, but and also to have um, to arrange for plasma metanephrines. The patient is not on any hypertensive medication, so we can send
Mm.
plasma metanephrine straight away.
Yeah, and there is any history of high blood pressure before
No,
or
and her blood pressure
palpitation?
her blood pressure is okay at the
It's not,
moment.
yeah.
So for this is um, uh, to rule out
Any other
uh,
workup you want to do for her?
mm, tilting table test, but
Yeah.
this would be arranged by the cardiologist usually.
Any other?
So I'd like to
Any other?
mm, in terms of specific tests, the Holter,
Yes.
which we'll be
What
sending the patient home with.
what what type of halter you will give her?
I will start. We will start since she's experiencing this on almost uh, uh, I'll start with 24 hour. If it didn't reveal anything,
Mhm.
we can go for 72 hours and
Oh,
then to 7 days. If it didn't reveal anything, loop recorder.
okay. Any management plan for her?
At this point, uh, we will wait for the bloods, and then I'd like to involve the cardiologist for an opinion to arrange for the cardiophysiological studies that, like the tape, the 24-hour tape, or the loop recorder, in order to facilitate reviewing of that, giving the patient lifestyle advice, um, and regarding cutting down uh, the caffeinated drinks
Mhm.
more, and to arrange a follow-up to review the loop recorder investigation and the ambulatory blood pressure monitoring we can that the patient is will be sent with. If there is a positive results, then we can arrange for discussing the potential management for this with cardiology.
Okay.
Okay, the
Thank
comment.
you.
Yeah, thank you, Dr. Omar. Thank you, Dr.
Thank
Ala. You
you.
can comment.
Thank you, Dr. Omar. Actually, well done. You approached the case very efficiently. Okay, you asked good about cardiology, the cardiac manifestations.
I
You
forgot to ask
tried,
about the 3 Ps.
yeah, the female history and the most also and also crucial thing you forgot to address the characters of these palpitations. Okay. You didn't ask about it is regular or irregular. Okay, you didn't ask how frequent she's having these palpitations, because this also will guide you regarding decision. You will need 24-hour only Holter, or you need for hair recorder to check what type of palpitation that she has. So the question about how frequent she's having daily palpitation, or it's like every other day or once per week. So this is important question, and also regular or irregular. If she has irregular, your mind will go that she has cardiac structural cause. Regular also you can suspect like any type of regular arrhythmia that she has. Okay, this is the only was crucial thing regarding the analysis of the palpitation. The other thing that she told you that she had COVID, and also we didn't analyze what happened exactly when she had COVID. Okay, how she treated, what happened exactly. She was, you asked about hospitalization. She told you that not hospitalized, but you didn't ask how she was treated during the COVID. Actually, she had the COVID and she was home isolated, and she was treated at home. And after that, she had this anxiety after the COVID, and she had tiredness. Okay, after this COVID. And the most compelling symptom that she give you, that when she changing the position, she had this palpitation. Okay, that the thing that she is guiding you toward this, what you have mentioned, this postural, like she has postural reflex, like she has postural orthostatic tachycardia. Yeah. Okay. So so that is that's my comment. So regarding this communication was only this is the defect only for the analysis for the palpitation. Okay, and as you have mentioned, also you forgot the woman history. But otherwise, you covered all things. You try to search for everywhere. You try to search for anemia. You try to search for the thyroid problem, phaeochromcytoma. Although a phaeochromcytoma, it's not a good differential here, because there is nothing to guide for, no hypertension, no headaches, no hand shaking, no tremors. So it's not a good differential here. So regarding the clinical examination, you covered also everything. You try to search also everywhere. And the concern also you addressed it efficiently. Okay, and mentioned the recorder or the holter that we need to check the type of the heart racing that you have. It's covered very efficiently. The workup that you did also was very efficient. Okay. I think mentioning also the table test was very nice. Only the screen also for the phaeochromcytoma, there was no need for it. So the differential in this patient, the first differential is the POTS, postural orthostatic tachycardia syndrome. The second differential for her is the anxiety and the excess coffee that she is taking, and also she has tiredness. Okay, and this you didn't ask also in the history, in the general history, the tiredness. She has tiredness also since she has COVID. Uh, this also can be like post-viral syndrome. Okay, post-viral syndrome, they can have tiredness, they can have anxiety, they can have also palpitation. Okay, but the first thing that they are putting here to flash in your mind when she is telling you that when she is changing position, I feel the heart racing. And actually, when I mentioned it to you, I thought you catch it. You caught
I
the
tried.
diagnosis exactly. Yeah.
I tried, but I was thinking, am I missing something? But
Yeah,
usually,
you thought it will not be easy. Yeah, it will not be that easy.
yeah.
Yeah, no, it can be direct, but the thing that they want you to search everywhere. They want you to exclude the other things. They want you
I
to
didn't
do.
practice the bots case like before, to be honest.
Mm,
So I was like doubtful to say uh, uh,
mm,
bots without ruling out any um, uh, organic causes.
yeah,
This was
yeah,
my way of thinking, to be honest.
but also the workup that you did also to exclude the organic causes was nice thing that you did. You put in the plan that you will do Holter monitoring, you will do recorder to, you will do ECG, you will do echo for her to exclude any organic cause, you will do thyroid profile, you will do full blood count to and the table to diagnose the bots. Okay, so you did the plan. You put the plan to confirm it and exclude other structural causes, and that's what they wanted from such case. Okay, so very well done regarding this. The other thing that I mentioned, it was very nice. Yes, that's it.
Okay, thank you, Dr. Ala. So, are you
Thank you.
agree about differential borderline? Because you didn't mention the diagnosis.
Yeah, and also the analysis of
Yeah, so yeah, he will be minus in this both
in the
skills, and
palpitation.
also I can add identify the finding. Did he do the posture hypotension or
Yeah,
offer
he
to do
asked
it?
it. He asked it. Yeah, he asked it
Okay,
also.
so
Yeah.
we can correct this one.
Physical examination, physical finding, satisfactory. Concern also satisfactory.
Yeah, I wrote them, but for the
Mm.
identify the finding, I thought he didn't ask about posture hypotension or to offer it, but
No, he offered them.
okay, so we can make it as satisfactory.
He addressed the driving also, and it was very good. Yeah.
Yeah, the good thing he also remember the driving, but the female history is important. The analysis of the complaint is very important. Dr. Omar, it's at least 2 minutes to ask about onset course duration, in particular with arrhythmia or palpitation, to know what is it, regular, irregular, fast, or slow. Okay, which he didn't do, so it can be a minus in the clinical communication. Okay.
Okay.
And other part of the history, yeah, I hope and I wished to do the clinical communication in systematic way, but I felt you are asking from here and there in random way, which is also not helping you to get good mark in the clinical communication.
I was asking about the for how long, when it started, has it came in, anything aggravating it, anything, how did it resolve by itself, and then the associated symptom, shortness of breath, chest pains, orthopnea, loss of consciousness, dizziness, and fatigue, and then the review of system, and then pass up the red flags, fever, night sweats, and then the past medical history, medication, allergies, family history. I forgot to ask about the female, and then the what do you do for a living, driving, alcohol and smoking, and I added the caffeinated drink. But this is how I was thinking inside. Or did it sound I'm going through
Yeah,
this way to you when you listened, or you because you told me that I'm going haphazard a bit. Um,
I mean for the systemic review questions, the chest,
mhm.
short of breath, abdomen, urinary, musculoskeletal, and neurologically before all of them. I don't know if you ask about the neurological manifestation. You ask about loss of consciousness only, right? But no
Yes, and I asked
weakness.
about no, I asked about the weakness, weakness, numbness, joint pain, back pain, pain in the back of the neck. Um, uh, yes, Dr. Ala can also confirm. I asked about those things.
Yeah, but the headache, I think you didn't ask about headache,
Um,
and it, and it's also a good
I
question
don't
for
remember.
pheochromocytoma if suspected. I don't remember also actually.
I don't remember.
But actually the
at that
approach is
time.
impressing. You covered a lot of things, and you like touched like the most crucial things. You know, something like the loss of conscious, the dizziness, the driving. These are the fatal things that if you forget, it will kill in the exam. You know.
No, I
Uh,
consider with palpitation, usually I put loss of consciousnesses with the flows or with the red flags.
yeah.
Fever, weight loss, change of appetite, and lumps and bumps. So I put loss of consciousness with neurology stations or palpitation, cardiac station, loss of consciousness, falls. I put it with them as a red flag. So a
Mm,
palpitation with loss of consciousness is a red flag. This is how I usually treat this, like in the back of my mind. This is how I
yeah.
deal with
Yeah,
it.
the anemia also one of the differential here. You can add it to your differential. It's very important differential to add, and you have to roll it out. You rolled it out from the examination during
Examination.
asking the question of examination. Anyway, it's 24 out of 28 is good in this difficult, but I think if you didn't reach the diagnosis, they might minus you and the clinical judgment along with the differential and of course identified or the clinical communication because you couldn't also analyze the palpitation itself. You have to know what type of palpitation you might have. Okay, this is my
Mm.
comment. The Holter, it's good to mention, and lobe recorder also for the paroxysmal AF, in particular if the patient is taking caffeine excess. So the differential was good apart from the differential or the diagnosis itself. Once you have tachycardia with the position change,
Mm.
you have to put it in your mind as a first differential.
So, and does it classically or for classically in the exam comes with the recent viral illness, not
No, no,
necessarily
no,
COVID, whatever, or
no, no. It
like as a
comes
clincher?
without. It was like distractor, I think, from Doctor
Yeah,
or it.
distractors. Yeah.
Yeah.
They are
Distractor
putting
or
the caffeine. The case actually came. The true case came that the patient had palpitation, and she went to the GP, and the GP diagnosed her as an anxiety, and he started her on diazepam. Okay, but she wasn't improving in the diazepam. Then he referred her. And this orthostatic tachycardia she had before, and she had COVID 2 months back. And after the COVID, she had tiredness and she low mood and anxious after the COVID. But this orthostatic tachycardia is before the COVID. That he asked also
is
good question that this is with you before or after the COVID.
Yeah, also, Dr. Omar, once you didn't recognize the type of pulse, is it slow or rapid? Vasovagal attack can be one of the differential if the case with bradycardia. Because also vasovagal attack happen whenever the patient is moving, and instead of being tachycardic, it will be bradycardia. So it's a big difference between POTS, which is post
posture.
postural orthostatic
Also,
tachycardia syndrome,
Mhm.
or the vasovagal, which happen with hypotension as along with bradycardia.
bradycardia.
Yeah, so it's totally different, but you have to put it in your mind. It can happen with the position as well, change of the position. Okay.
Mhm. So for the palpitation, how frequent, how regular you
The
felt,
time.
Yeah,
and I tried to, yeah, I didn't ask for them in particular by name, but I tried to figure out for how long is it all the time? Does it come in episodes?
Yeah, all this question is valid or are valid, but the type of arrhythmia you didn't know. Is it fast or slow? This is the most important because you cannot diagnose
Mhm,
POTS without knowing that he is feeling awareness or fast or a racing of his heart, right? And you
mhm,
cannot diagnose vasovagal unless he will tell you, doctor, I feel my heartbeat slowing down. Take care of palpitation or awareness of heartbeat or whatever the change of the rhythm. You have to analyze it in this way, either increase or decrease, regular or irregular. If you can
mhm.
also add one step to analyze, to tap on the table. Is it like this regular one or tap on the table with a regular one, like uh, randomly tapping? Okay. So you will know,
Okay.
yeah, you will know what palpitation you are talking about. By the way, awareness of heartbeat is one of the complaint. It can be as fast or slow. Palpitation mainly as a fast one.
Mhm.
Okay. Do you have any question?
No, is there anything that I missed in the management? We should
No.
refer to cardiology only, or is there anything
Perfect.
we
You
can
mentioned the
do?
Hill table test, okay, which is also diagnostic tool here. Instead of being vasovagal or bradycardic, the patient will have tachycardia. So the Till table will be the diagnostic in both. Yeah, Dr. Tani is asking what is the POTS? Postural orthostatic tachycardia syndrome. It came before in PACES. It's rare case, but it comes in this way. So take care. You have to know it. That's why we have.
In past test video, I always skip these spots.
No, it's very important one. It came, I think, frequently. It's a rare one, but it came frequently. So
Yeah.
don't underestimate this topic. It's very important. And as I said, vasovagal, it's the top differential. If you have awareness of heartbeat or feeling syncope or feeling dizzy, but instead of having tachycardia with the position, you will have bradycardia with the changing position or standing long. Okay.
But bots doesn't need
Mm,
to
mm.
diagnose with bots or give it as a diagnosis. Does it need or does it require ruling out any other like organic causes for the
No,
palpitation
no
before
organic
giving the
cause.
bots? No need. Like, does it require that we've ruled out this list of organic causes of palpitation? Now
Yes,
we
you
are
have to
diagnosing
rule
with
out.
bots.
You have
Okay.
to rule out thyroid. You have to rule out fucocytoma. You have to rule out cardiac. You have to rule out stress. You have to rule out caffeine. All the differential you mentioned, but you have to mention the POTS and the
Mhm.
top of them, since you hear the patient has this symptom whenever he changed his position.
For driving, shall we stop driving or we shouldn't?
Since you don't know the diagnosis yet and he feel it with the changing position and he might have dizziness on it with it, you can tell him please hold on your driving until
Mhm.
we have clear diagnosis. After that you can talk about driving.
Is it
However,
like yeah.
it doesn't change. It doesn't change with the setting. It comes only when he change in the
Stand.
position. Yeah, or
So
stand after.
I tried to ask that does he feel the symptoms behind the wheel?
Yeah, good
Because I
question.
felt
Yes.
it could be like if it's like vasovagal.
Yeah,
Um,
it's a good question because some patients they will have related stress or stress related vasovagal,
mhm.
which is not our case today. You ask good question. Does it happen while driving or behind the wheel? And they will say no, doctor. So you can say okay, temporary or meanwhile, please hold on until we have clear diagnosis, just for the welfare point.
Okay.
Okay. Yes. Okay. Thank you, Dr. Omar. Any other question, Dr. Ala or Dr. Omar? Anyone want to add?
thank you, Dr.
Any question, any differential, any point to be added? Anyone want to comment?
Thank you, Dr. Bassem. Thank you, Dr. Alaa.
Thank you, Dr. Omar. Thank you.
Okay. Dr. Mahjoub is there. Anyone want to add any comments? Clear all this the session?
Yes.
Okay. So we will wish you so you see you tomorrow inshallah with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam.
Alaikum assalam.
الله الذين كفروا بغيظهم لم ينالوا